So I hope I can be seen and heard. I would like to welcome everybody to this next surgery section of and I'm happy to have all my colleagues with me, and special thanks goes to Thomas Kretschmer for organizing this webinar, and of course for ENS, especially Anna Reck for her ongoing support in our activities. And well, we have some controversial and very interesting cases ahead. And this webinar is meant to be based mainly on question and answer, not the chat. For all your questions, and of course for all comments, please use chat or question and answer, whatever you prefer, just to get in touch and to have this webinar as lively as possible. So thank you for joining, and let's start. Thomas, please.
And the first to start is actually Radek. So I'd ask Radek to present his case, neurofibroma of the median nerve in the hand.
So hello everyone, I'm starting to sharing my screen. Please let me know if you see something. Yeah.
Perfect, yes.
See the screen.
Perfect.
Okay. So hello everyone, good afternoon. It's a great pleasure for me to be here with you and present our case, which is quite controversial, I hope. And this is a large tumor in the hand. So it's about large, not only neurofibroma, but any kind of tumors in the hand. Sorry. So this is a case of a young woman, 40 years old nurse, who was seen 3 times previously in different departments, and she was operated on for tumor in her hand in 2017, and it was large tumor mass in her distal forearm and hand, and she underwent biopsy and some kind of neurolysis. And from biopsy, histology was neurofibroma. And since then, she was seen in other 2 neurosurgical departments and refused at all times because she still had some median nerve function preserved. And on the photo on the top, you can see the scar from the previous surgery after neurolysis. And when she came to our clinic, outpatient clinic, she suffered from severe hypesthesia of the 2nd and 3rd finger, severe pain, and progressive loss of hand function. And she literally desperately wanted to undergo some kind of surgery because she couldn't do anything with her left hand. And on the images from the MRI, you can see the tumor mass. T2 and T1 after contrast on the right side. So she agreed. We indicated her for surgery. We explained everything, and she agreed with loss of median nerve function. And we performed resection of the tumor last year, and histology was plexiform neurofibroma. She improved her hand function, and anesthesia of her fingers was quite tolerable. And these are pictures from the surgery, so quite large tumor. And this is half year after surgery, situation half year after surgery. She developed pain in her distal forearm, and on control MRI, there was a tumor mass with enhancement after contrast. And clinically, there was local pain with clear Tinel sign. I explained her then that I thought it was terminal neuroma, but the problem was that someone told her at her local hospital that it could be sarcoma. So she was cancerophobic, and due to progressive pain in the forearm and differential diagnosis of sarcoma, we did the revision surgery, resected the tumor at the end of the proximal stump of the median nerve, and obviously histology was terminal neuroma. And now the situation is, it was this year, the situation is that she's waiting for plastic surgery, tendon transfer to improve thumb opposition. And these are controversies, I hope. So first question, when to operate or resect so large tumors of the important nerves? How long should we wait? Secondly, try to reconstruct the sensory function of the median nerve from ulnar or radial nerve. And first question, revision for terminal neuroma, once only or repeatedly, when will it stop? Somewhere in the brachial plexus or where? So that's all. Thank you.
Thank you, Radek. Great case. So you already posed your questions. So please leave your questions there. So I'm maybe somebody from the panel already wants to respond. Would you have also operated and on such a large tumor in that location? Alan.
Thanks, Radek. Really interesting case. Thank you for the presentation, and they're all great questions. So I guess on the first question, would we operate? Is this part of neurofibromatosis, or is this an isolated tumor? Does the patient have a syndrome, or do you think this is just an isolated neurofibroma? Let's begin with that.
It's isolated neurofibroma. Yeah, she was examined in the Department of Genetics, and it was negative.
Okay. So one of the interesting things is you said you resected the tumor and that improved her hand function. When you take out I'm assuming you took the whole median nerve with this tumor, why would that produce improved function?
Well, because this was her hand before surgery, before our surgery. Yeah, she couldn't grasp anything, hold objects because of severe pain. She couldn't, literally, she couldn't move with her fingers and so on. She was asking for anything to do, to resect or to do something.
Right. So in this case, if we go back to your questions, if we were going to operate on the tumor, and that's certainly an indication to operate on the tumor, one would understand that she's probably going to lose her median nerve function. My approach would have been, if I'm going to take out that tumor, I'm going to graft her right at the time of surgery. I'm going to try to run grafts. And the reason I'm going to run grafts, I don't think you're going to get back necessarily motor function, like for instance, to the abductor pollicis brevis, but you do want to provide some sort of sensation, protective sensation to the hand. So if you were to graft the median nerve to the terminals, to the sensory terminals, you should be able to get back some sensation. Also, if you put the grafts in and you do get return of some sensation, that will decrease the chance of getting a pain syndrome later. So in your third question, what do you do with a terminal neuroma? The best way to treat a terminal neuroma is not let one develop. And the way you don't let it develop is to graft the nerve in the first place and try to reinnervate the hand, prevent the terminal neuroma from developing because you graft it. So that's would have been the approach I would take. If you still, if you didn't graft it originally, you can go back now, still graft it if you want to, because if you can find the terminal branches, the sensory branches, you can still run grafts. We know that although you may not reinnervate motor, you can reinnervate sensory, years later. So that would be a reasonable approach even now to try to prevent neuroma. Or you would put a cap. We would do a muscle cap, targeted muscle reinnervation on the top of the median nerve to try to prevent a painful neuroma. It would be one of the two things. Resect the neuroma and graft it and try to get back to the original sensory fibers, or put a piece of muscle on the end of the median nerve to reinnervate the muscle and prevent a painful neuroma.
Thomas, I would follow Alan's opinion and approach. I have several cases like this. One of them might be presented in some of our presentations before. I would. This was a case similar like this, but neurofibroma was in the upper arm, not in the forearm. And we did just exactly what Alan said. We made a radical resection and then made the grafting immediately, made a distal nerve transfer for this, and somehow there was no recurrences, and there is nice recovery 1 year, more than 1 year after surgery, in terms of hand function. I mean, patient is very satisfied. I have that case. I can present it in some of our further series, but generally, this is how we also approach to this problem.
Radek, can I ask?
Especially when you have isolated nerves with the tumor distal.
Yeah, I agree. We discussed everything with the patient, obviously also grafting, but the problem was that the defect was quite large. So it was, I think, 13 centimeters. So I explained her before surgery, so that to reconstruct the nerve, I would probably need both sural nerves, and that was the problem. Yeah, so she told me that she would like to try just to resect the nerve, and then we'll see. So that was our approach. I don't know if we still, if there is still possibility to reconstruct it 1 year after surgery. What do you think? If there is still place for regeneration 1 year after surgery of so large, so long defect?
Yes, you can still reconstruct. It depends on what you're trying to target. If you're targeting sensory, you can reconstruct a year later, 2 years later. If you're targeting motor, probably not. So you're not going to get back abductor pollicis brevis, let's say, but you could get back some sensation. And more importantly, you'll try to prevent a painful neuroma at that point.
This is also important to present the patient immediately before the surgery to all these details.
Mm-hmm.
What just Alan mentioned.
Radek, what did you do on the revision surgery to prevent neuroma recurrence?
Well, just to put the nerve between the muscles. Yeah, but the problem with median nerve is that it's quite large, so it can't be. If we compare it with, for example, a small digital nerve, if you put it in somewhere into the small muscle in the hand, it will remain there. But the problem with median nerve in this case was that I couldn't stitch it there or to glue it there because it couldn't stay in place. So that was the problem.
One way around that is to split it into fascicles. So you convert a big mixed nerve into 5 or 6 fascicles and then either bury them individually into muscle or puts a small allograft and give it into different muscles in the neighborhood.
Radek, could you, for the audience, could you explain what you had in mind with your second question? So I believe you were thinking about a transfer.
Yeah. Right now we were discussing immediate grafting, but if there was other possibility to reconstruct median nerve function from other 2 nerves, would you or do you think, is there any situation in your clinical, or was there any situation in your clinical practice you were thinking about it to cut sensitivity from ulnar nerve or radial nerve and transfer it to median nerve to reconstruct other sensory nerve?
Yeah, we've done that, and it works just fine. The hand surgeons do that rather routinely, and they'll take one of the sensory nerves from the ulnar, from one of the nerves coming up, and just transfer it over to one of the other sensory nerves. And it actually works well, and that's a pretty routine thing for the hand surgeons. We've started doing it. It was a little scary at first, but I got to tell you, the hand surgeons, it's a routine kind of thing.
Because the problem is that the patient can if you lose the sensitivity from ulnar nerve, you'll finish with total anesthesia of your hand. So this might be scary. How to explain it to the patient? What it will fail?
So one of the more radical approaches to that we've tried with a little bit of success is we took the sensory ulnar, so the dorsal branch of the ulnar nerve that goes to the back of the hand. We took that branch because you can get a big long length, cut that, wrapped it in the front, and put that into a median nerve to try to get back some sensation in the hand. It worked so-so, wasn't great. We thought it was a good idea at the time.
Okay, so I think we had an in-depth discussion of that, and we can move on to the next case. Unfortunately, Christian has got some web problems. That's why I'm talking. So Ellen, we'd ask you to talk and present about sciatic nerve repair and positioning.
Hoping this, ooh. Okay, I'm hoping that's up. Is that working? Okay, so just a quick history, Johns Hopkins. So neurosurgery, we think of modern neurosurgery starting with Johns Hopkins and Harvey Cushing, and back in 1901. And this is a neurosurgery group. So just to let you know that though we think of Harvey Cushing as a brain surgeon, he was very much a peripheral nerve surgeon. Did a lot of peripheral nerve cases, and he published on peripheral nerve cases and so on. So it's not fair to just think of Harvey Cushing as a brain surgeon. He was absolutely a peripheral nerve surgeon as well. And that's the original hospital of Hopkins versus there's the original hospital now surrounded by almost a city of a hospital. The current Johns Hopkins. Okay, case report. I'm going to present two cases. First case, a 20-year-old male was shot in his lower leg. It was a stray bullet. Unfortunately, and he was hit by a stray bullet. Had a complete perineal nerve palsy. And at 5 months, we decided that we were going to explore this because he wasn't showing any spontaneous recovery. We do intraoperative physiology, where we do recordings to see if there's any conduction across the neuroma site. In this case, there was no conduction across the neuroma, and so we decided to do a repair. These are our intraoperative conductions. Dave Klein had originally described this. We've perfected it a little bit different way, but basically we do conductions across the neuroma to see if it's conducting or not. Here's his perineal nerve, tibial nerve. There's a neuroma over here where the bullet went across, or at least very close. There's the neuroma. And again, the conduction across this didn't show any conduction, so we felt that needed to be resected and grafted. Now, when you resect and graft, you're left with a gap. And the question is, if you cable graft this, what's the result versus if you do an end-to-end repair? And most of us will agree that if you don't have to graft, and if you can get a direct end-to-end repair, that's always the best way to go. So here's his repair. And you see, in fact, we've stitched the nerve back together. There's the tibial, there's perineal, and we have a direct end-to-end repair, no grafts. So how did we resect this and then have enough nerve to bring end-to-end? Well, the secret is you can see that we've flexed the knee. When you flex the knee, you gain length, obviously. So we flex the knee, end-to-end repair, some tissule glue over top. Now the question is, what do you do with that flexed knee? Obviously, if he straightens it, it's going to pull apart. We used to use the external fixator, but a lot of my patients, when I would do this, they'd take it off, they'd stretch their knee, we'd have problems, and they'd pull it apart. So we went to an external fixator. The external fixator is like what they use for growing legs. And here's this particular patient again. We've put the external fixator on. We've bent his knee 90 degrees, end-to-end repair. And now we're going to very slowly extend his knee 10 degrees per week for about 9 weeks. We wait a month or two to allow this to heal, and then we start extending at about 10 degrees a week, and they do very well. All right, so that's case one. Case two, the one I want help with. This is a current case. 34-year-old male. He was stabbed by his estranged girlfriend. This was August the 7th of this summer. Sciatic nerve injury, a Sunderland grade 5, meaning right through his sciatic nerve. A 2.5 centimeter gap now exists in his sciatic nerve. When we flex his knee to 90 degrees, we can get a direct end-to-end repair. Consideration was, again, do we put the external fixator or do we just put an external brace on him? Now, he's a 34-year-old male. He's the manager of a luxury car dealership. And we felt, okay, he's a pretty responsible guy. Rather than put him in the fixator, we'll put an external brace on, give him a month or two to allow it to heal, and then gradually extend the knee out. So again, we did an end-to-end repair with the knee flexed August the 7th, 2.5 months ago now. Okay. Patient compliance is a problem. We now hear that he's been taking it off, putting it on. He doesn't like it at times. He finds it difficult to sleep in. So now I see him and I decide I'm going to do an MRI to have a look at the nerve. So he comes in his fixator, but I know he's been taking it on and off. This is an MRI done with his knee bent at 90. But what you can see here is a gap. There's the sciatic nerve coming down, and there's a 1 centimeter gap where we don't see continuity of the nerve. The cut here you see a nice vesicular pattern of the nerve just proximal to this gap. Again, nice vesicular pattern, just proximal. About a 1 centimeter or slightly less gap, and then the nerve again. Okay, he has a Tinel's right in this area, but he's only 2.5 months out. We wouldn't expect that Tinel's to be much further down. At 2.5 months, a little gap on MRI. Do I re-explore and decide whether or not the nerve's still in continuity, or should I wait? That's my question, that's my dilemma, and this is, as I say, current right now. I have to make a decision. If I wait, how long should I wait? If I re-explore, is that the way to go?
So, Alan posed his questions. Is there a response from the panel right away?
Alan, would a good ultrasonographer be able to tell better about nerve continuity?
So, very good question. There is a person who does high resolution ultrasound that we work with. This is a high resolution MRI, and I can tell you, I don't think we're going to learn a whole lot more with the ultrasound, because that gap is less than 1 centimeter. It's about 8 millimeters. I don't know that it's truly a gap. It looks like that on the MRI, but it's a little unclear. And there's not a proximal swelling. The key here to me is that I don't see a neuroma on the proximal end, suggesting that the axons are tangling. And he's 2.5 months into this. So I would think it would be bulbous. This is how our radiology actually read it out. Focal gap, 1 centimeter, without retraction or bulbous enlargement. So I think an ultrasound is basically just going to show you the scarring in this area, and you still won't know whether that's a neuroma in continuity, whether the nerve has actually pulled apart slightly. Not sure the ultrasound, but if somebody feels strongly, we'll do that. Dr. Hanna, should I re-explore it? Should I leave it? What should I do?
If there is a possibility this is not a real gap, I'd probably give it another 2 months and do an EMG, get him clinically, and if there is no evidence of recovery, I'd probably explore and do nerve action potentials and make a decision based on that.
My EMG, I don't think will have any impact because he already has hamstring innervation. So the first muscle, if we think about it, would probably be biceps femoris, short-headed biceps femoris. And that's going to be several months away, right? Because this injury is mid-thigh. So to get down there will take at least, let's say, 4 months, 5 months from the time of repair. Should I wait that long for a possible EMG, or do I do something earlier?
I'd say earlier with nerve action potentials, intra.
Okay.
I would also re-explore it. because you might lose half year, and then what will do next?
So if you re-explore it, what is it you're going, what's the finding that's going to change things for you? If you re-explore it, and let's say it's together, but it's very firm, which is the most likely thing you're going to find is a big firm kind of mass.
Neurogram, nerve action potential. Intraoperative electrophysiology, and to see if there is a regeneration through that area or not.
Okay, Luca, what do you think?
I would explore.
When? How long do you give them? Go now or wait?
No, I mean, whenever you find this situation, I will explore as soon as possible in terms to clarify this.
So let me ask you this. If I re-explore it, and let's assume it has come apart a little bit, I would think I'm going to have to trim it. I'll be left again with a 2 to 3 centimeter gap at least. I've already flexed his knee 90 degrees. Now I've got a 2 to 3 centimeter gap mid-thigh. What's the chance that I'm going to graft that and he's going to get a functional recovery in his sciatic distribution? He'll be at least 5 months into it. That's
true, but the case is completely controversial, as we are presenting controversial cases. So this is something that we have to let's say make some decisions based on different aspects. I mean, this is something which I have some experience with similar cases, but not with using this external fixator in terms of moving his leg, and this is something which might be useful to let's say clarify what is the possibility to do in these circumstances, because you are following this patient excellently, and now you have to. I would explore. That's it, and then we will make it up.
Thomas.
I'd probably also go in direction of exploration, because we had in another nerve which is more favorable. We once had a similar experience, which was the radial nerve, and we all are aware that the story is different with the radial nerve, but function-wise, what you want to get, at least you want to have some sensory protection from the tibial part of it. So that alone would be important enough for me to secure that there is no gap. So before re-exploration, I probably go for ultrasound. There is a chance that the ultrasound won't help you that much. On the other hand, if the nerve is still in coapted and in continuity, I doubt that you will do much harm just by quickly re-exploring, but then it's from the table. You don't, there's no question anymore. Okay. And if not, then you will have to decide if there's a possibility that you can shorten it just slightly and mobilize, or that you will have to put in a graft. And then at least you have the chance for some sensory function. And there was the other aspect you also mentioned. It's in continuity, but you're not sure if the internal structure is still okay. That again would be another case for intraoperative ultrasound, which can be quite helpful I would believe, in a situation like this.
Okay, so let me ask the panel this. Let's say it's a 2 centimeter gap. Would you use allograft or autograft?
Well, for us, it would be easier decision, because it would not be that easy to get allograft. And we I'm not sure if we would even have to justify that, if it would be allowed. And it's I just got to know, at least in Germany, it's very expensive, and so we would have to use autologous graft.
It's very expensive here as well. Dr. Hanna, am I justified using allograft for a 2 centimeter gap in the sciatic nerve?
Yeah, I think either way is fine. I think although there's more data for digital nerve, I think for a 2 centimeter gap, you should be okay. I have a question about your first repair. Was that wrapped in a tube or not?
The first one was not wrapped in a tube. That was a direct end-to-end repair. I do 1 to 2 8-0 epineurial sutures and then apply tissue glue.
Just a seal, okay. Yeah, I think it would be fine either way, although I think neurosurgeons lean more towards autograft, plastic surgeons lean more towards allograft. But I think the data is out there for short gaps. I think you could go either way.
Okay. And then our fallback on this, final comment on it, our fallback, if we don't get back protective sensation in the foot, which is truly critical on this, what I have done with these patients is a transfer where we'll go and take the saphenous nerve, the distal part of the saphenous nerve, and transfer it over to the tibial nerve, just above the ankle. And we can get back some protective sensation that way. So that's helped a little bit as a fallback.
There's a question from the chat by Willem Pondak. So he was asking about, that has been answered in part, no allograft, autograft, or fascicular split as suggested by Assmann.
That's a very good question. I have not done that split. I would just, frankly, if I have to graft this, I would be going with autograft. So I would simply harvest seral for this and do a seral nerve grafting on it. I don't think I'll ever get an end-to-end again.
Could you just shortly explain that kind for the audience, that kind of the fascicular split?
It depends. I'll leave that to you. Thomas, can you explain that?
I'm not 100% sure, but I think what is meant by that to take part of the sciatic nerve that will not a high chance of recovery, which is part of the peroneal part, and use that for grafting the tibial part to bridge the gap, which is it's actually an older technique.
I was going to say, so people have tried that and they've used various components of sciatic and done the same thing in the arm with ulnar and so on, where they'll take a part that's targeted towards sensory, for example, use that as grafting. So that's been used here. I would not want to do that because I'd be hoping we're going to get back some motor function, both in peroneal and tibial distribution, because we went in, this is an immediate repair, and it's really about maybe a year for regeneration in terms of the distance. So I'd be hoping we could get back motor function. So I would not want to split the nerve and try to use some of it. You could make an argument to use one of the hamstring branches, but his hamstrings are quite functional. So I would just go with serals. And it would be bilateral serals for this.
Okay. I would have another question regarding your first case. You mentioned external fixator versus external brace. What would you prefer with your current experience?
So now that I've done this patient, so again, here's the external fixator, and that works really well. The patient has no choice. The physician's in total control. And for some of these patients, obviously, who've had gunshots and stabs, it's a very nice way to go because we have total control. Using the external fixator is much better than this external brace. But if the patient is truly compliant, they do the identical thing. The problem is keeping the patient compliant. And you can imagine it is uncomfortable sleeping with this, and you can imagine a patient will get a little fed up. And that's why although it does the same job. This one, they have no choice. The other thing is, this comes with software that you can very accurately dial in. So as you start to extend the knee, the software tells you exactly how many turns to do at each screw, and you can very accurately then re-extend the knee. So I like that external fixator. In retrospect, I probably should have used it on this patient, even though I thought he was going to be a very compliant, a very easy patient to work with, but he's not been that compliant.
And how did you come up with your time schedule? 10 degrees per week or?
Oh, so again, the external fixator software, basically what I want to do is I look at how long it's going to take me, how much I want to extend the nerve. So if I think of the nerve as growing 1 millimeter a day, is what we usually think of axonal regeneration at 1 millimeter a day, then I want to stretch the patient back out at 1 millimeter a day, certainly no more than that. And that's what you basically dial in. You say, well, I'm looking at 7 millimeters a week then that I want to stretch. And if you dial that in to the software, it tells you exactly how many degrees that will be. It's very straightforward mathematics when you think about it.
Okay, so thank you very much. Christian, are you connected still, or? Oh no, he's got a very bad connection. Sorry, so I have to keep on talking. So we'll have, thank you for this very interesting 2 cases. So we go on with Lucas, the 3rd case, entrapment syndrome versus nerve sheath tumor, diagnosis and management.
Just to share my screen, you see now screen, I think.
We've got your screen, looks good.
Yeah, just to make a slideshow. Yeah. Well, good afternoon. Once again, it is my pleasure to present this case as we are discussing about controversial cases. This is a quite controversial case. I present this case in some circumstances. Some of you might know the case, but generally speaking, it is quite interesting for the audience to learn this case, because it can be very, very problematic. So I don't have nothing to disclose, just to take your attention to the title of this case: multiple crash syndrome, cubital tunnel neurofibroma, and malignant peripheral nerve sheath tumor. This is something which is, let's say, what happened in the end, but this is something entrapment or not syndrome. So I don't have nothing to disclose. And this was a male, 37 years old, operated 6 months before in the other institution due to the cubital tunnel syndrome. Clinical presentation: numbness and pain at the level of the medial part of the left forearm and the wrist. Hypotrophy, clinical findings: hypotrophy of the hypotenar and interosseous muscles, impaired abduction and adduction of the fingers of the right side. Then EMG findings: cubital tunnel syndrome and radiculopathy of the C8 and T1 spinal roots on the right side. Then MRI of the C-spine, tumor of the right lower trunk with no signs of propagation, nowhere. So patient was operated because of the cubital tunnel syndrome 6 months before. He came to us, and he came to me, and then we make this kind of evaluation, and we find this. So we proposed the surgery, and it was exploration of the lower trunk. Patient accepted everything. I mean, the important issue in this situation is to discuss with the patient about all details, as we mentioned in the beginning of this webinar. But particularly in this case, we present the patient all options and possible treatment modalities, and then we explain what is the meaning when you have let's say resected the lower trunk of the brachial plexus, and then we agreed that we will go for biopsy. Then we made the biopsy, and after biopsy, clinical findings were uneventful. He recovered well with no additional neurological deficit, and we do not have possibility to do extempore biopsy and histology so far. And a few days after that, we received this kind of histological finding, diffuse intraneural fibroma. So this is a polling question for the audience. Just to make this, let's say once again, would you consider resecting the whole inferior trunk after this histological finding? So 6 months after surgery.
Just Luca, before you go on, can you just define for us fibroma versus desmoid versus neurofibroma?
No, this was a pure histology. We didn't have a possibility to explore this genetically, and because after that patient was discharged, and when he received the histology, we invite the patient. He didn't appear. Then he appeared lately, and then we appeared practically 6 months after surgery for a control examination, and with the worsening of his previous symptoms. Then we did again MRI spine, which showed unchanged findings, and the EMG showed more pronounced findings at the level of the right cubital tunnel, and MRI of the right elbow showed signs of the compression of the ulnar nerve by scar tissue. So the MRI was unchanged after surgery with 6 months after that, and we decided to re-explore the cubital tunnel syndrome, and we then made a let's say nice deliberation of the ulnar nerve from scar tissue. Then the operation was fine, and we discharged the patient. Then 3 months after that, the deterioration of the patient condition, pain in the whole right arm, inability of abduction and adduction of the fingers of the right hand, paraparesis on the legs, and he could not walk without the help. Then further evaluation showed that tumor of the lower trunk shown growth and propagation into the spinal canal. Then we again discussed with the patient, and we told him that now we have to do whatever we have to do, and he agreed. Then we made extirpation of the neoplastic change C8 and T1 roots, lower trunk, and its anterior and posterior branch. Then we made a laminoplasty C7, T1, T2, and extirpation of the tumor, which was completely this is a mistake, not mural, intradurally located. And we received pathological findings for malignant peripheral nerve sheath tumor. But patient recovered well, he could work independently, and then we discharged the patient. Then this is a kind of recurrent surgery, images from this kind of surgery, section, and this is a laminoplasty. And 1.5 months later, patient come back to our institution he was paraplegic. Again, MRI of C-spine, recurrency in the spinal canal, and then One more surgery, laminectomy C71 and 22, extirpation of the tumor, which was completely located now extradurally, no signs of the tumor intradurally. And then again, malignant peripheral nerve sheath tumor, and patient condition was, after operation, was unchanged. He was sent to the radiotherapy, chemotherapy, and physical therapy, but unfortunately, this patient passed away several months after this. So, sorry. So this was the case. And question is, I mean, situation is that we are not able to make this kind of, we were not able at that moment to make this kind of genetic exploration. And after we retrospectively made this kind of genetic exploration, he was already on the second phase of his treatment in terms of having this. So this is a very controversial case in terms of how can we be sure in these circumstances what kind of genetic or any kind of investigation should be necessary to perform immediately, since we received after the first surgery, when we made the biopsy, which might be a, let's say, bad sample, or not enough sample, or let's say bad, not good histological evaluation, or not enough material. So question is this: diffuse intraneurofibroma, whatever it means. Diffuse intraneurofibroma, you have a lower trunk, you have a function, you have a situation with them. This is what you see in MRI. Patient recovered after surgery well. We wait for the results of the histology, let's say around 7-10 days. I don't remember now exactly, but approximately results from histology we are waiting. It's for approximately more or less about 10 days. At that moment, patient was at home, and when we received this, we tried to contact him. We didn't have a response from him, so we then leave it like it is. And in this situation, should we resect, or what should we do with the inferior trunk in this situation when you have this kind of tumor on the inferior trunk, or any kind of any part of plexus, but generally speaking, on MRI you have this situation. Everything is fine, everything is clear with the spinal canal, and nothing else is affected except the inferior trunk with the solitary tumor, or might be other middle or upper trunk, or any part of the plexus of the nerve, but generally this is an inferior trunk, which is particularly in this case additionally controversial.
Lucas, can I ask you a question?
Yes.
So if I got it right, your first histopathology did not confirm malignancy.
No.
Correct?
Exactly. That
so
was
your first question is
this is the first pathological finding: diffuse intraneurofibroma without signs of malignancy.
But did you trust this histology, because it sounds a little bit strange?
This is something what I mentioned before. I trust this histological findings because this is our histological, let's say, laboratory from which we are working for 20 years and more than 20 years. We have let's say, we are confident in their findings, and this is something which they are experienced pathologists, especially regarding nerve. But pathology nerve surgery, and we didn't have a problem so far.
Okay. Can I just, I'm trying to be Christian right now because he's SMSing his questions. So I'm just reading his questions because I think they're very helpful. Who does the pathology? Query reference center. So this is, he's alluding to, even if you've got a very experienced pathologist, some centers always send for additional reference pathology. Then he's asking about pre-op FDG PET. And then he's asking about pain at rest.
Okay. University Clinical Center Institute for Pathology, which is our referential pathological institution, is doing this histology for us. We usually do not send this to the second opinion or expert opinion in different centers around Europe, because as I mentioned, this is so far it was not any kind of let's say this kind of problem. This is another question. Maybe sample was not good. Maybe sample was not enough. Maybe sample was let's say taken from the part from the part of the lesion which has no particular malignant aspects. You understand me?
Just the capsule.
Yeah, no, just the capsule. It's not a capsule. We try to make it go through the capsule and go through the fascicles to take some different parts, but generally, this is, you cannot be sure in this situation what is this. And then,
Lucas, was there a plane between at that point was the first surgery? Was there a plane between the mass and the lower trunk?
It was not. It was not clear plane. If there was a clear plane, I will remove the tumor and leave the lower trunk. You understand me?
So it's a really instructional case, a very informative case, and a very tough case, and one I think everyone would struggle with. The first biopsy is clearly, was an inadequate biopsy. I don't mean it was done inadequately, but obviously we had a sampling error because it should have shown a low-grade, probably sarcoma, something like that. Yeah. Intraneural fibroma is actually a very uncommon diagnosis. That's why I was asking you, were they thinking desmoid or something more like that?
Yeah.
Once you have, after you go past the biopsy, when the patient presents with the tumor that has grown dramatically, and they're coming in now with a myelopathy, it sounded like, at that point, I think everyone would have to assume it's an MPNST. That's the only thing that grows that quickly and that badly. At that point, I agree with Christian. Before I reoperated, so before I did that first spine operation, I'm going to go in assuming I'm dealing with an MPNST. Therefore, the whole operation changes. We're going to do a PET CT pre-op to make sure that we don't have any metastatic disease. If it's already metastatic, all you're going to do is decompress the spinal cord. If it's not metastatic yet, and you only have the isolated MPNST, then we're going to try to do a gross total resection. And everything is going to go, including the original tract where we did the biopsy. Everything we're going to take out very aggressively and then radiate right away.
Yeah. So you are talking about this phase. Now we receive the biopsy first, and then we have a 6 months after surgery when he came for a follow-up examination. Then he came with a worsening of his previous symptoms. Then we did an MRI of his spine. We showed unchanged findings. We showed EMG, AMG with pronouncing findings at the level of that. These are all experienced investigators within my, let's say, our Center for Peripheral Neurosurgery, including radiologists, including neurophysiologists. And then we didn't make in this phase PET scan.
So that makes sense.
We
But then it's the next presentation. It's after this, when he comes back with a massive tumor.
After this, we have this. After this, we have this. 3 months after cubital tunnel surgery, we have a deterioration of the patient condition, pain in the whole arm, inability of abduction. It's already rapidly, foudroyantly transformed in the tumor, and the tumor mass was like this.
So that at that point, that's an MPNST.
Yes.
You're going to go in assuming it's MPNST.
Oh no, at that point it was clear. At that point it was clear. At that point we immediately do this. Extirpation completely.
I wouldn't have done that.
Total resection, everything, etc., etc. And then we showed the patient to the oncological department for further investigation. They didn't recommend the PET scan.
But
we would recommend, but generally speaking, they didn't recommend because he was recovering from this situation in a very short period. After that, which is
wait, go back, Luca, go back.
Yeah.
The question becomes, and it's what I think it was what Christian was asking. I would ask the same question. Go back. One more slide. Where you see the MRI.
Yeah.
You and I both agree that's going to be an MPNST.
Yes.
So if we're assuming it's an MPNST, before I do the surgery, I'm already going to start with oncology and say we have two choices. We're either going to simply decompress the spinal cord and buy the patient time, or we're going to do an en bloc as much as possible, huge resection for negative margins, treating it as a sarcoma, as an MPNST. And therefore, we would want a PET CT done before the surgery to make sure that we understand whether it's already metastatic, things like that. I think that's what Christian was asking, and I would agree with him. The time to do the PET CT is before you do that operation, because if it's already metastatic, you're not going to do some big en bloc resection. Plus, some people would radiate ahead of time. That's controversial, but that's a reasonable approach at that point. If you do an en bloc at this point, your first spinal operation, you could make the argument to do a very aggressive en bloc resection of the whole sarcoma. And that would be the chance for cure. That's really the only chance for cure in this patient, would be an en bloc resection at that point.
So it was this is only a small mismatching here was in terms of communication with the oncology department and the development of clinical condition of the patient and possibility to have a, let's say, emergency PET CT evaluation and everything to let's say make a coordination within all of this within 2 or 3 days, because patient was radically worsening and has severe pain. He was, let's say, in a very difficult condition.
Mm-hmm.
And we discussed to make this kind of surgery and to make this kind of and patient agreed to make this kind of situation, to make a gross total resection of everything what I present, and we made it. And then patient recovered well after that, and then he should walk independently. But this was lasting 6 weeks. You understand me? In between these 6 weeks, this is something which moved to, this is photos for the surgery from the patient, but this is 6 weeks in between when he wound is healing, everything is coming, and he is coming on his leg. And now we are planning to go for oncology to take a PET CT and everything to do. Again, we have a very rapidly worsening and foudroyantly worsening. So maybe an approach to this problem is to make PET CT at the very beginning of treatment of this patient, to assume immediately that this is a let's say possibly malignant peripheral nerve sheath tumor before the first surgery. I mean, before the or even immediately after the first surgery. And then we start to do this in some circumstances.
Lucas, can I bring in some other aspects? This is an excellent case, but we have a question explosion from from the questions and answers. So the one thing that is still coming from Christian, the other aspect about PET scan is, the one is to look for metastasis, as Alan said. The other thing is, if you have a tumor that you don't trust and it's still benign, follow up FDG PET scan can help you to detect some hotspots or some development also in the follow-up. And Fernando Guedes, who is another nerve specialist and nerve tumor specialist, apart from hi everyone, says, how was the biopsy made? What kind of imaging technology was used? PET scan to biopsy hot areas, question mark. Annie Dubuisson is asking, don't you have to question the cubital tunnel syndrome? And there's a colleague, I believe it's a Russian colleague, I can't read the name, it's Cyrillic. Why did you not operate this patient after his first visit to you?
Okay, Alexander Odzhensky, I will go from this direction because he made the question first. We operated this patient as soon as he came to us. He was operated from cubital tunnel and inadequately diagnosed in another institution 6 months before he came to us. And because of the worsening of his symptoms and the idea that he had in his head, or some other reference doctor who referred this to us, is that he has a non-adequate surgery for cubital tunnel syndrome. And then we start to investigate the patient, and when we explore and let's say identify the tumor of inferior trunk. And then we made I'm going now to the Fernando Guedes question. We made an open biopsy after MRI, which was quite sufficient at that moment. We didn't make the PET scan. We didn't see any other problems in this, and that is an issue. Should we made at that moment assumption that this might be some kind of potentially malignant tumor, and made this kind of evaluation before any kind of surgery, including biopsy? Before the first surgery, very first surgery from us, not surgery from the other institution when they made surgery of the cubital tunnel. And now I going to the Anne Dubuisson. Don't you have the question? The cubital tunnel syndrome. Well, we immediately realized that this is not at the moment of the first operation, that it is not an issue of the cubital tunnel syndrome. That's why we made this, let's say, double crash investigation in terms of having this in other aspects evaluated. But at the moment that you mentioned, Christian is mentioning all other, Fernando and Alan, my question is, should we make this PET scan at that moment? Because after biopsy, because we propose the patient to, let's say, if we find a tumor with a clear plane and should remove the tumor and preserve lower trunk, we will do it. It was not the case last like Amgad asked. It was diffuse tumor, and I decided within the surgery, it was practically surgery, open biopsy, but surgery, exploring the inferior trunk. Not to resect the inferior trunk, but to take biopsy. They took biopsy not only from the capsule, but from inside the fascicles, several samples, but obviously it was not good. It was not enough. It was not precise, or was something, I don't know to explain.
Okay, so just last round with this very fruitful case. So there's one comment by Christian. The big problem in these regions is that tumor-free margins are nearly impossible to achieve. And then, and this is please the last questions with quick response. Do you share the experience that sometimes surgery worsens or even triggers malignant transformation? I would have to say yes.
Me too. I agree completely. I agree completely for the second question, and this is for the surgery. For some reason, somehow, in my opinion, assist in inducing malignant transformation. I don't know how to explain it. To explain it, let's say more than this, but generally speaking,
I don't think so. I disagree.
Okay, Radek and Amgat.
Yeah.
I don't know. I have one more question. If you
we will have to really round it up because
okay. No problem.
But pose your question. But we can't discuss it in very long.
No, I'm sorry about this, but obviously case is really controversial and maybe for I don't know.
Radek and Amgat.
Yeah.
Yes, sorry. We operated on similar case, but in lumbar spine. It was extraspinal clear Schwannoma according to MRI. During surgery, it looked like clear Schwannoma. It grew from one fascicle. We removed it completely, and histology, the patient was good. And after 10 days, histology came, and it was really surprised because it was MPNST. And there was need for revision surgery because of recurrence in 1 or 2 months. And we resected the whole L5 nerve root, but it grew into the lumbar plexus. And the patient died within 10 months, I don't know. So if you have experience with gross total resection in this area to resect the whole lumbar sacral plexus in these cases, or these huge surgeries.
I think the only case where it's documented that surgery could cause malignancies in desmoid tumors. I don't think there's any data for malignant transformation after nerve sheath tumor being removed. The only thing, if you do a biopsy, you just have to incorporate that in the more radical resection when you do the more definitive surgery.
Yes,
with the biopsy track.
That's true. I mean, that's completely correct. But generally speaking, this was more like let's say observational let's say evaluation that in some situation, if there are histologically proved malignant peripheral nerve sheath tumors, we have several cases, like it was the first case in Radek presented, that you have a recurrence, although you made an extremely radical resection, taking out complete median nerve or sciatic nerve or everything in a, let's say 5 centimeters margin from the tumor and everything, and then you have again recurrence for some reason. This is something we have those cases. I mean, I will.
But it's a sampling area, Luke. It's a sampling. That's just sampling errors. If you look at the sarcoma literature, this is typical in the sarcoma literature. Surgery does not cause transformation of a benign tumor to a malignant tumor. All that happens is we have sampling errors where we don't get necessarily the malignancy in our original sample. And when you do a very large resection with a large margin and you get a recurrence beyond the margin, that happens routinely in sarcoma surgery. It's simple that some of the cells have already traversed where you think you're getting a margin. Some of the tumor cells have gotten into lymphatics, other tissues, and they get a recurrence. That's common in sarcoma. So we have to think of MPNST as a sarcoma. It behaves similar. That's straightforward.
That's exactly like it is. Like
so let's not call it transformation, but spread.
But somehow, let's say, progression of the disease is appearing to be coincidentally with surgery. Let's might say it like that. You understand? Not to say that surgery induced malignant transformation, but progression of the disease somehow have a coincidence with starting of surgical treatment.
Yes.
Okay. So we have more Q&A, but I think we have to look on the time. So so I think Christian would like to say that it's my turn to present the next case.
Yes. So I'm stop sharing.
Okay.
The screen. No, I'm stop sharing the screen. Okay. We are finishing with this case. Okay.
Okay.
Thank you. Great.
Okay. So do you have my screen?
Yeah.
Okay. Okay, this case is about a bilateral neck tumor, and I'm asking about several. I'm asking your opinion on several aspects. So history: 46-year-old female, active office worker. Already in 2003, and this is a current case. A small mass on one of her vocal cords was detected due to hoarseness, and that mass was successfully removed, and it turned out to be a tiny schwannoma. The further imaging workup revealed further bilateral small masses at the neck. There were no integumental stigmata. And the astonishing thing is that the growth was observed without indicating any surgery in the following years, 2007, 2012. And 2020, she's 45 years of age. And in the meantime, her neck circumference massively enlarged. She has intermittent spontaneous coughing and subjectively feeling easily out of breath, despite being athletically active. And sometimes she describes that she has to concentrate to swallow. And also during rest, sometimes she feels a tracheal constriction. This is those are the current images of her. So this is a very slim woman. So you see her neck, and let me quickly show the video. So what would be your quick diagnosis? Okay, think about it. So we just
Did she have imaging of the head?
We could think about a vagus nerve schwannoma. There's even there's a recent article on the trigger for cough, and those are the images, the current images of her. So the thing is, it extends up to the jugular foramen bilaterally, and it does not stop here, but it extends to the mediastinum. In 2003, it was much smaller, but that doesn't help at all right now. So the constriction she feels is real. The trachea is already constricted. And it is also for real that sometimes she has troubles swallowing. So just to point out a few aspects. Of course, this is supposed to be a vagus nerve schwannoma. So this is another patient of ours with a much smaller vagus nerve schwannoma that was only 7 centimeters and extended also to the jugular foramen. This is pre-op and this is post-op. So on intention, we left the part in the jugular foramen. This is on the 4th day post-op, so the vocal cord function is not that bad. And to me, all of the difference is that we were able to do a vagus nerve monitoring by direct placement of an electrode and by using a vocal cord monitoring tube. So this is surgery, and this is the placement on the distal part of the vagus nerve with that kind of electrode. And despite accurate monitoring and good response by accessory nerve and also good response by glossopharyngeal nerve, we only had slight dysphonia. But it turned out after a while, what you can see here on 1 month later, that we had accessory nerve palsy. And if you look on this picture, I actually got quite frightened because this is a high accessory nerve palsy because the sternocleidomastoid muscle is out. 2 months later, good recovery of the sternocleidoid muscle and also of the trapezius. So there's a recent article on jugular foramen schwannomas and so on monitoring. So obviously, in the case I presented, it will be very difficult to find a proximal or distal end of the vagus nerve. So would it be justified to do this kind of monitoring, meaning going even to an intracranial level to directly stimulate? So those are my questions. What should I do next? Surgery, yes or no? Then what is the goal of surgery? What is the surgical approach and strategy? Any tests you would do prior to surgery? How do you monitor during surgery? How do you counsel the patient? Which side do you operate on? When do you operate on the other side? And what do you do for bilateral vocal cord paralysis? She's an office worker. She has to do a lot of work by the phone. What do you do about a high spinal accessory nerve palsy? What would you do about glossopharyngeal nerve palsy? So this is my case. Thank you. Whoever wants to start.
Why don't you start with the diagnosis? Are you calling this schwannomatosis? Are you calling it NF type 2? Are you calling it a mosaic form of schwannomatosis? What are you labeling it?
We'd probably call it a schwannomatosis, NF3, because there have been previous schwannomas, and then we have other 2 schwannomas, and we have, for example, more imaging of her neurocranium. There are no other tumors so far that we are aware of.
So the only medical therapy for schwannomatosis is bevacizumab. There is evidence that if you wanted to treat this with a medication rather than surgery, there's some evidence that bevacizumab could be used, and there's papers on that. So that would be one approach if you felt.
Which is still off-label, right?
It is still off-label, yes, but it's published that there is a response to bevacizumab in patients, and it's one of the few drugs, the only drug I know of that's been shown to have any effect. So that would be one possible approach.
So we have documented growth, and she has trouble to breathe and to swallow already. And she's young.
I'd probably debulk one side at a time. Maybe start on the left side.
Why on the left?
I think the left side is more forgiving. That's why we put the vagal nerve stimulators on the left side. In terms of cardiac complications.
But on the left side also reaches all the way down to the mediastinum. So there will be no chance to see the vagus nerve or to put an electrode on the vagus nerve, also on the left side. And the larger side is the right side.
Can you
So
put the
more
film,
compression from the right side.
Thomas, can you put the films back up so we can see that?
Yes.
There's always going to be growth. I guess the question becomes, what is the true indication for surgery? Is it the coughing? Is it what's pushing you to want to operate?
I think the tumor needs to be debulked because it grew considerably, and there is tracheal and esophageal constriction already. So I was thinking about debulking with an intracapsular approach, the right side first. And if we want to get rid of the tracheal constriction, we probably have to go even as far down as possible, and we would have to do a partial upper third sternotomy.
So the question in schwannomatosis always is, what are you trying to achieve with surgery? What is the indication for surgery? In a case like this, you know that each time you go in, it's going to get harder, right? There's going to be more scarring, and your ability to do an intracapsular decompression or decompress without causing a lot of neurological problems, it gets more challenging. So that's why I'm pushing a little bit to truly understand at this point, why operate? We don't want to treat an MRI, we want to treat the patient. So what is it about the patient's presentation at this point that's pushing you to operate rather than an MRI finding?
She has troubles to breathe.
So are you going to improve that breathing by your decompression?
I think that can be reached, yes.
I would put that to the panel. What are you going to achieve? What has to be the goal of surgery? When have you done enough surgery in this patient, in this particular case, to achieve that goal? Because Thomas is presenting this that he wants to improve her breathing.
I think you have to decompress the trachea and esophagus.
But the one side would be enough for this indication, for this goal.
And do you think, is there, and again, I would just want to know, have you done a sniff test? Do we know that the diaphragm's working unilaterally, bilaterally, that the phrenic nerve's intact?
Phrenic is working. No more comments? I need some help with this case.
Refer it to ENT, have them do it.
Pardon me?
Well, ENT or some surgeon who is experienced in let's say neck surgery.
You know, ENT is even saying with a tiny case that I presented with a 7 centimeter vagus nerve schwannoma, no, that can't be done. Forget it. You will have deficit, and then sending the patient to another country.
Yeah.
That doesn't really help.
Can someone hear me?
Yeah.
He was observed for several years.
Yeah. So the bottom line is, if you're going to operate, again, you have to have a clear goal. And I agree with you. If you're feeling that it's the breathing, I would want to know with a pulmonologist that they agree with you this is because of tracheal problems. You know, somebody needs to make sure that you're, again, doing the surgery with the right indication to operate and the right end game goal. And if the end game goal is to decompress trachea and to a lesser degree esophagus, it's going to be a fairly aggressive decompression. And reasonable to go right side first, get inside the tumor, stay inside the tumor, and truly do intracapsular. As soon as you get on the surface of the tumor, you'll cause neurological deficits, even if you very carefully lift the fascicles off. So don't even try to do that. Just stay with inside and decompress.
Not to get me wrong, even if I stay intracapsular, I think we will have complete loss. We can do the endotracheal tube monitoring, but it's by far not as reliable as the monitoring with the electrode that I showed you. So there's actually also the patient, of course, is very frightened of the growing process, and she completely understands the problems with these cases. And it's one thing if you have deficit on the right side, but if you would have deficit bilaterally, that.
Yeah. So I agree with you with the monitoring and stimulating. That's often very useful. The key when I say to stay intracapsular is the difference of this case versus just a humongous schwannoma sitting there is because this is schwannomatosis, and I agree with your diagnosis, this may well be multiple tumors stuck together rather than one large schwannoma. So when you stay intracapsular, you truly have to stay intracapsular. And it may mean that you go into one tumor, debulk from within, go into the next tumor, debulk from within, and separate out the beaded tumors. Where people make mistakes here is thinking they're getting inside the capsule and they get fairly aggressive. What they're really doing is getting into multiple tumors rather than just one tumor, and you start knocking off the little fascicles that are going into those extra tumors. So that's where we've seen problems. That's where I've gotten into problems. And what I've learned, and actually that one cartoon drawing from Bob Spinner at the Mayo that shows, little beads all together in schwannomatosis, try to remember that. And remember that when you get in, this is still going to be multiple tumors stuck together. Go tumor by tumor individually. And that's how you stay safe.
There's one comment by Christian. He says right vagus is sinus node. So for him, his choice would be left side. What do you think about this? Okay, any more thoughts on this?
So what
The thing is, we are probably asked to do surgery. Okay. All right. So we come to the fifth case. It's about a cervical mass. Again, Amgad, your case.
Okay, could you stop sharing?
Yep. Actually,
Do you see mine yet?
No, not yet. I'm trying to put in a.
It still says you're screen sharing, Thomas.
How about now? Do you see mine?
Okay.
Yes, we see yours now.
Okay, great. Thomas, I have to congratulate you on this webinar. I've never seen a webinar with 89 attendees, so this is very well attended. Here is my case. 45-year-old male presented with a gradual onset neck pain radiating to the left arm. He has tingling and numbness down the left arm. Started about 2 years ago in the left scapula, underwent some chiropractor manipulations and some massage, and that helped some. There's no history of trauma. We started PT, physical therapy, gabapentin, standing desk at work, and that helped some. Otherwise, in the history, there's hypertension and obesity. 5/5 strength in MRC grades, and there's decreased sensation, lateral forearm, so lateral antebuccocutaneous nerve, the left thumb, so kind of C6 distribution, median nerve, deep tendon reflexes are normal, and no Hoffman sign, no clonus. And here is on the X-ray. I can point you into the scalloping of C5 and C6 in that area, if you can see my mouse. And here is just a yellow circle here around the area where we see the scalloping of the vertebra, notifying us that this is probably a chronic, probably benign process. On further imaging, here's the MRI, and here's the mass. And this is coronal. You could see the mass enhancing on the left side, probably centered on C6. Then we got a CAT scan to figure out how much of the vertebral body is actually being eroded. And we did a CTA to see the relationship with the vert. Turns out the vert is probably draped, likely draped anterior to the mass based on the radiology report. So panel at this point, biopsy, resection, or observation, or something different. Lucas.
Let me think a few minutes, few moments.
Alan?
Okay, so I'd wanted a couple of things.
Okay.
You asked, first of all, they're really good questions. The first question is going to be, am I going to do anything? So his presentation is still fairly benign, whereas my operation is going to be fairly aggressive. So a biopsy is not really realistic. It's hard to get a biopsy of that lesion. So you're going to have to make your decision on imaging. For that reason, I would want what we call ADC values, diffusion coefficient, to see if this looks like a very cellular tumor. You could also do a PET CT in the same fashion, but I'd want to know if this has any malignant features to it at all. I suspect it doesn't, given it's been there for a while, but that's going to help you decide whether you want to operate now or not. If you're going to operate, the problem here is you want to make sure that you've got a vert that on the other side that's going to compensate in case you get into the vert on this side. I agree with you, the vert's going to be draped on it. Normally you can peel these off the vert, but you always have to be prepared to embolize the vert and make sure that the right side vert is there to compensate. If, for example, you don't have a right-sided vert, I'd be very hesitant to consider operating on this. Then comes, if you're going to operate, what are you going to do? You're going to probably cause a C6 deficit. Was 5/6 the foramen or 6/7?
5/6 foramen.
So assuming this is C6 root, it's going to get damaged with the surgery. Hopefully not, but you're going to assume he's going to lose C6 with a big, you would be doing a big facetectomy and then just stabilize above and below, but do a big facetectomy so that you could get the whole tumor out from the back, which normally you can if you do a big facetectomy. And then it's just a question of what do you do with the vert? Do you embolize ahead of time? Try to embolize the tumor off the vert? Try to be prepared to deal with the vert bleeding? Again, those are the ways I'd be thinking this through. And again, I'm assuming he has no other stigmata of neurocutaneous syndrome.
Okay, so the answer to your questions, I don't have a PET scan, I don't have an ADC, but I did request a CT-guided biopsy. The patient was twirling around a lot. They couldn't get into the tumor. It came back as fibromuscular tissue. So my guess is they missed the lesion. My question to you, looking at the axial, you think you can attack this from the back or from the front?
You can take this all out from the back. This would all come out from the back with it. As long as you do a facetectomy, you can take it all from the back.
Okay, Rodek, biopsy, surgery, or observation?
I would also go for surgery, but the question is if it's better from the back, because as I see it on the pictures, I would go rather from the front or anterolaterally, like something like George approach or something like this. To me, it looks easier to go there from the front.
Okay, Thomas, same question.
I would go from anterolateral. Reason being, I also want to have vascular control. So not from the back. And there's a comment from Willem Bondak. He simply said to the question biopsy or no, bigger than 3 centimeters, so biopsy. And I think I would like to have a biopsy.
Maybe I missed this in your presentation, Amgad, but did you make a PET scan to this patient?
PET scan? No, I don't have a PET scan. I did get the biopsy, and again, they probably missed the lesion, so it came back as fibromuscular tissue.
Okay, so I will go for surgery also, anterolateral.
Okay, so I planned on anterolateral surgery. I planned on getting ENT involved, and also decided to talk to my endovascular colleague. As Alan alluded to, we want to know the condition of the right vert, which vert is dominant, and I actually planned on balloon test occlusion of that left vert just to be completely prepared for the surgery. Okay, so this is the biopsy, and then here is the angiogram. It turns out it's all a pseudoaneurysm. It's a dissected vert on the left side with a giant pseudoaneurysm, and it's not a nerve sheath tumor. The right vert was open and probably a dominant one. So the treatment at this point is going to be endovascular, likely proximal and distal occlusion of the vert. They're still considering whether they're going to stent that or do an occlusion. So yeah, tough case, and with everything, this was looking like a nerve sheath tumor, the chronicity, the scalloping of the vertebra, the C6 radiculopathy. There was nothing here to make me think that this is pure vascular lesion. The biopsy could have been disastrous if they actually got inside the lesion or bit the aneurysm. And when I went back and told the radiologist that this was an aneurysm, he said, "Hallelujah! Thank God I missed the lesion."
Yeah, but did you make this? Did you make this investigation? I mean, you make this before the surgery, so that's if you know this, maybe there's something. Decision-making process will be different. We'll go directly for surgery. We'll try to explore all possibilities from vascular side.
Yeah, this was in preparation for an open surgery to resect the tumor, but obviously, once we saw this, we didn't do any open surgery.
So that's
Patient
it.
patient will be treated endovascular.
Yeah, that's it.
Great case. So
Yeah.
going back now and looking at that MRI in hindsight, is there something that we should learn to look at that MRI to know that this was vascular and not a tumor? Is it should we be looking at those flow voids and saying that's, you know, hemangioma or something like that until proven otherwise?
It might look like that, yeah.
You know, Jed, is there something you would look at now that you could teach us in retrospect, looking at the MRI?
I think it's more the CTA, because if you look at this,
Yes.
I thought this was contrast. It's probably just filling with blood. And when you look at the foramen transversarium, again in retrospect, this is like, it looks like the vert is not there. It's just replacing the vert and just opening up that foramen transversarium. And in retrospect, I think it's easier to call on the CTA rather than the MRI.
Again, I think you're right, and I don't want to be boring, but it would be very interesting. It's not stented yet, right?
Correct.
Just try it with an ultrasound probe. If it would be suggestive of vascular malformation.
So I have another question for you guys. It's interesting looking at this, especially the foramen transversarium, as Amjad pointed out. In talking about your surgical approach, if we assume it was a tumor, and again, fascinating case, and you know, it's great having it presented. Let's assume that was a tumor, a nerve sheath tumor. I'm the only one who wanted to go posterior. You guys all want to go anterior or anterolateral. The reason I want to go posterior on this is because I've been burned in the past where dealing with that vert from the front is exceedingly problematic. All you can really do is pack it off. You can't see it. You can't deal with it well. When you come from the back, you can usually get the tumor out, debulk the tumor even if you want, and then find the vert from the back and protect it. And that's why I, on this one, would come from the back and not the front, because I'm petrified of that vert, getting into the vert from the front and not having any ability to control it, see it, find it, work with it. So it's interesting, I'm the only one who wanted to go from the back, but that's after doing a lot of these from the front and having trouble with the vert. I don't know how you guys would protect that vert when you come from the front, or especially if you're coming anterolateral and you're really coming lateral. The vert is the last thing you're going to see.
Not necessarily. If you think about a wide, in principle, it's a wide sides approach, right? Like for spine. If you have the tumor mass on the side, and I think it pretty much also depends on a retractor system. You can go from the upper part, and you can go all the way around. And so I have pictures where I skeletonized the word. So I think I'm faster there, and I have more control. That's why I'm not coming completely from the front, more from the side, and I would not feel as safe from completely posterior. Plus, I'd have to dig through all the musculature, and here I can in the beginning you can directly aim for the sternocleidomastoid. Regardless how large the tumor is, the sternocleidomastoid will be on top of that, and you can use that sheath to come around the tumor. And I don't know if I explained it right, but that's sort of how I'm trying to approach from anterolateral.
No, but this is in this case, it can be, let's say, both approaches evaluated, because this is something which might be approached posteriorly also. But I will prefer anterior lateral, like you said.
I was just going to go in full force with ENT and my vascular neurosurgeon. With ENT, we would probably just completely transect the SCM to work both medially and lateral to that. I think if you leave the SCM, it's going to get in the way, and then just have the vascular guy there to help, and hopefully just stay inside the tumor capsule. I would think if I stay in the tumor capsule, I'd probably keep debulking without having to deal with anything that's outside of it.
But you don't have to transect the SCM. It can be very nicely retracted medially.
Yeah, but a good part of the tumor is almost like an ACDF approach. A good part of the tumor is almost reaching the midline. So you could retract it, but you're going to struggle all day, I think.
It's very mobile. I agree with Thomas. We've come on both sides of SCM in some of these tumors. And once you do that, the SCM actually can move quite readily. You can move it around quite a bit. So it's long, once you get the longest colli down, which is usually thinned out to nothing anyways, the SCM moves and you can work on either side of it. So that's reasonable.
Okay.
Great case. That's a really instructive case.
Thank you very much. Thanks to all of you. I think all these cases have been great, and there was a lot of discussion. Let me just quickly check Q&A again. I think we pretty much have it. So great to have you here, and I hope to see you soon again for another round of case discussions.
Yeah. This will be some kind of, let's say, case series webinar discussion, which might become a traditional VNS section for peripheral neurosurgery. And this is something which we have to develop, because it was very, very useful. And Christian is not able to join, so I will say a few words. We have any continuity in next webinars, monthly series of webinars of VNS, so you will receive all information and join us either as a panelist, either as participants, because I saw in a question and answers pool that there are a lot of our colleagues and friends who are active in peripheral neurosurgery section and in WFNS committee for peripheral neurosurgery, following this through different channels, asking questions, which is very, very, very good, and I'm very happy because of that. And of course, great respect to the ENS for giving us support to the platform for making these webinars. And Christian, can you try to say something to join? I mean, you can try to say something, but can you try to establish the connection with internet? So this is the, let's say, situation with this. When everything is fine, internet can be a problem.
Well, Christian seems to struggle. Even the messaging is not functioning anymore.
Anyhow, Thomas, you can if anybody would like to say something, you can conclude the seminar, the webinar after that. This is something which we are almost 2 hours. I believe there are a lot of participants, but we will receive the report of how many participants were present later on. And we have in last year, we used to have approximately about 400 or 500 participants. I mean, not participants, but people who are watching this.
So I think Anna, thank you very much, Anna. Maybe we can stop recording. I think we're done with the webinar.
Yeah.
Yes, of course, I'm stopping now. Thank you.
Thanks.